Good evening, everyone, and we thank you for joining us for Season 5, Episode 19 of Doc Talks with Dr. Forrest Tennant and friends. We have so much ahead of us this evening, and we have Patricia Irving, and she has some special things to share, but Dr. Tennant has some special things to share before that. So we'll go ahead and let you all start, and thank you so much. It's all yours.
Thank you, Jamie. This is a very interesting and profound meeting because we're going to do something that's probably never been done in this country before, and that is something that is formed out of necessity, and that's an organization, if you will, called the National Campaign to Protect People in Pain. And thanks to Pat Irwin, who we're going to hear about in a few minutes, and you've got some other esteemed people who are members of that campaign, like Red Lawhern, Mark Ibsen, and a lot of other big names. The bottom line is this is a movement for the first time to where we really have some first-class people and a first-class cause, and certainly we want to make Doc Talks available to help with this campaign, and we're going to get to that in a little bit. To get the educational part of our program going today, however, I want to read you a very short letter I received this week. It says, "Dear Dr. Tennant, I'm wondering if there's a different type of medication needed for the muscle spasms that come from arachnoiditis and not muscle strain. I've tried multiple muscle relaxants and very few work, and those only work when taken at higher dosage and then I just sleep. Are there other medications that decrease muscle spasms when the cause is coming from adhesive arachnoiditis?" Now, this letter touches upon several things. In the last couple of sessions, we've tried to educate people that if you have constant pain, you're going to have three components to that pain. Now, you only feel one pain, but therapeutically, you've got to treat three components. That is the ascending pain, the descending pain, and then something called neuropathic pain. Now, just to review this quickly, ascending pain is the bioelectricity that is formed from your injury or disease site. In other words, if you have neuropathy of the leg, you've got fibromyalgia, you've got RSD of your arm, you've got arachnoiditis of your spine, that's your injury site. Now that site's going to generate bioelectricity that's going to go up the spinal cord, and it's going to approach a group of receptors, of which the main one is the endorphin receptor or the opioid receptor. It's also going to approach the cannabinoid receptor, the serotonin receptor. But at any rate, and we treat that pain by using receptor activators like opioids, like cannabinoids, like ketamine, things like that. Now, descending pain is when the central nervous system either can't process all the bioelectricity, or it's developed its own injury site, usually from autoimmunity, when that makes glial cells dysfunctional, sends bioelectricity back down the spinal cord or down the vagus nerve, and that's controlled by a different receptor known as the noradrenaline receptor. And the opioids don't help that kind of pain. Benzodiazepines don't help that pain. What helps that pain is a certain group of compounds that attach to the noradrenaline receptor, and such things as tizanidine, clonidine, propranolol, Ritalin, modafinil, and so that group of drugs controls that pain. Now, there is something called neuropathic pain. This is the term that has been adopted. You can find it 8i. It's now adopted, and you're going to have to live with this term. It's called neuropathic pain. Okay? Now, it actually is the pain that goes with the derivation of the word. Neuro means nerve tissue, And pathic means sickness, okay, pathology. Another means a sick nerve is what that means. Now, neuropathic pain is the big rage. It's the big love affair. It's the big money. It's the big controversy. All of you are caught up in it, whether you realize it or not, okay? Now, neuropathic pain, let's go over the types of it. And first off, the controversy, the misinformation, the promotion, the big money involved with neuropathic pain almost knows no bounds. And it's become almost an ugly situation. Let me see if I can explain it to you. Now, neuropathic pain, what it means is that you've got somewhere, whether it's in your brain, your spinal cord, or whether it's in your nerves in your legs or in your muscles or your carpal tunnel or your trigeminal nerves, it means that you've got something wrong with that nerve. That nerve has become dysfunctional due to some reason, okay? A disease, an autoimmunity, a virus, a trauma. Something has interfered with that nerve so it cannot conduct the bioelectricity normally. So what happens? If you can't get the electricity to pass this injury site, it backs up, it accumulates, it causes inflammation, and so you've got this sort of ball, if you will, or entrapment of bioelectricity, okay? And now that's why such things like acupuncture might relieve some of that. Something like a massage might relieve some of it. In other words, you've got to try to get the bioelectricity flowing. Now, it turns out that there is a chemical in the nerves or the spinal cord or the brain and a receptor that transmits that bioelectricity in the nerves, and that receptor is called it's a big long name, it's called the gamma aminobutyric acid receptor, okay? Now, for short, it's called GABA, and you'll see that GABA in the literature on AI, on Google. So when you see GABA, it stands for that big long receptor, but it's also a chemical, and it's a neurotransmitter. Now, if you have enough GABA, that electricity, and enough receptors that work, then you can get the bioelectricity to pass. Okay? Now, we didn't know this sort of pathology or system for a long time, but we've had drugs around for centuries that work on that system. For example, some of the herbs that work on that and make the GABA work, make the receptor pass electricity, such things as kava, valerian root, ashwagandha. Those things actually work on the GABA aminobutyric acid receptor, and they're activators or substitutes for the neurotransmitter. Now, here is the thing that I want to get back to the letter I read you for just a minute. I want to show you my prop for the night. It's a funnel. It's actually a drug funnel, and it's a big long one, and it's about the same size as your spinal cord, okay? And inside this little hole down there, you have the cauda equina that comes out this pipe, okay? What is arachnoiditis? It's when some of these cauda equinas gets trapped by adhesions on the side of this funnel, okay, of that pipe. That's what is adhesive arachnoiditis. Now, adhesive arachnoiditis is known for the name, but it's also a mass. It's also a scar. But more than that, it is an entrapment. It entraps the nerves, okay? Now, those nerves, there's about 21, about 24 nerves that hang down from the spinal cord and are called the cauda equina. Now, if some of those are trapped in that mass that go to your legs, you're going to have muscle spasms. If you also might go to your feet, your feet are going to burn. If it goes to your pelvis is going to burn. And it's also going to throw your muscles into spasm because those nerves that are entrapped in what we call adhesive arachnoiditis cannot pass the bioelectricity. So that's why adhesive arachnoiditis is nothing but a big ball of adhesions, inflammation, and bioelectricity. And we try to use different techniques to free that up if we can. Now, the big thing, one of the first bits of misinformation about neuropathic pain is almost ridiculous to talk about. It's like all diseases, it's mild, moderate, and severe. But one of the bits of misinformation down here is there is no such thing as mild, moderate, or severe pain. Just give them more of the same drug. Now, some of the drugs that make the bioelectric pass, let me talk about some of the old ones, and then we're going to talk about some of the new ones. Now, the old drugs that were out there, the first one that became famous was one called Meltown back in the late 50s and 60s. Then the one that came out also about that time was something called carisoprodol or Soma. And then around 1964, what I call maybe the best of the bunch was a drug called Valium, diazepam. And those were the drugs that were given for passing bioelectricity. Now, there was a separate group of drugs, however, that were marketed for muscle spasm. And they do work on the muscle. But this lady who wrote doesn't have a muscle problem. She's got a nerve entrapment problem. Okay? Now, this is one of the bits of misinformation. Modern medicine, if the muscle is in spasm, they give you a muscle relaxant. They don't bother to ask why you got it. Okay? Why do you have it? Do you have a nerve that's being blocked somewhere? Well, in the case of adhesive arachnoiditis, you've got a lot of them that are blocked. And you're going to need potent drugs to get that electricity, hopefully, flowing through that through that scar. Now, let's get down to what's going on today with neuropathic pain. And excuse me if I sound a little hostile or bitter about this, because it just is one of my great pet peeves as what's happened here. The whole game has been because to push these drugs that are being used for neuropathic pain, there's about 3 or 4 of them. The big one's gabapentin. The trade name, the most popular trade name is Neurontin. The second big one is Cymbalta, duloxetine. The third one is pregabalin, that's Lyrica. And for some reason, baclofen seems to be a big popular one. And I guess the fifth one probably out there is Effexor, that's venlafaxine. And some of your brighter pain specialists might give you something called Topamax, seldom used, it's very expensive, but works quite well. But those are the drugs being promoted, okay? Now, let me give you some things that I see every once in a while. It has come to pass that gabapentin is being used in dosages that shock you. It probably has a ceiling effect of about 600 milligrams, maybe 900. And when it doesn't help your pain, they just go ahead and give you another 900. And now we have papers coming out about people being overdosed with it, people abusing the drug, but in high doses it's too high. But the big thing that I want to caution you about, we now have all the benzodiazepines being restricted. I mean, the whole idea that you would take Soma is almost heresy. But if you've got adhesive arachnoiditis, I'll be honest about it. I have found that unless you're taking a benzodiazepine or Soma, you're going to be lucky to find a neuropathic drug that's going to work very well. Now, some people do get some help with gabapentin, and they do get some help with a pregabalin, but those are mild cases. And so one of the bits of misinformation is that mild, moderate, and severe, and you've got a severe entrapment like adhesive arachnoiditis, you're going to need a benzodiazepine, you're going to need Soma, you're going to need something else. But what's going on, as you know as well as I do, it's all drug promotion. There's no money in Soma. There's no money in old Valium, it's off patent. So they want to sell you these new drugs that are on patent. Now, all I can say is that's all right if they would at least recognize that their drug's more potent than pregabalin And baclofen, I think, is pretty worthless for adhesive arachnoiditis. Now, a couple of other things that I want to tell you about before I close this on. There isn't a week goes by that I don't hear about somebody being force tapered off their benzodiazepines, just like the opioids. Okay? And the benzodiazepines, now they've got it talked to where there's a black box around the FDA regulations, but any doctor can still prescribe it. There are doctors out there now that have been told by their medical boards, been told by their insurance companies, been told by their hospital, never give an opioid and a benzodiazepine to the same person. Never prescribe Soma when somebody's taken an opioid. That's ridiculous. If the case is bad enough, and adhesive arachnoiditis is the worst case you can have, the two drugs they're put together is perfectly not only acceptable, it should be done. Okay? So, and one last thing, if somebody's been pulled away from their benzodiazepines and you can't get them, I'll give you one little trick. If you get kava and you get ashwagandha and put the two together, you can make your own Valium, okay, out of these herbal compounds. And lastly, you can actually get pure gamma aminobutyric acid as tablets, and you can't swallow it because it's a natural compound that is digested by the stomach, but you can put it under your tongue. It kind of has a nicotine, a nicotine effect, if you will. You can kind of get you can get quite a jolt from it under your tongue, but it's also a great pain reliever at times. So anyway, there are some options about this. Let me just summarize it, because neuropathic pain is real. When you've got terrible conditions like RSD, small fiber neuropathy, severe arthritis, EDS, adhesive arachnoiditis, you're going to have a neuropathic drug along with a drug probably for ascending pain and one for descending pain. Okay, you got to have these things, and those people who have been force tapered are going to have to depend on maybe the other classes. You got three kinds of pain you got to deal with, and you got to get good relief. And if you're only dealing with one or two, well, you're not going to have a good day. That's about all I can tell you there. Now, this gets me into where we need to go. It is very clear that most people think it's the DEA and FDA, and it's the Congress, it's the federal government is causing all the problems for patients. That's not true. They're causing enough problems. But in each state, there's a medical board, and those medical boards control the doctors. We have some states that have excellent medical boards, and we have some that are just awful. Okay. And if you are a pain patient who's having to take opioids, having to take benzodiazepines, you've got one of these terrible intractable pain conditions like small fiber neuropathy, you need to know about the power of your medical board. That's where your complaints need to go. And all I can tell you is I'm going to turn you over now to Pat Irwin, who's going to talk about our new effort to try to work with medical boards. In my opinion, today, if you've been force tapered, if you can't get the medications you need, if you are forced to have a shot in order to get your opioid prescription, if you've got that quid pro quo, if you're at the end of life and you can't get help, let me just remind you that just yesterday, the Wall Street Journal actually said no one should die without dignity. We've got people all over the country dying of cancer, dying of arachnoiditis, dying of all these problems, and can't even get a Vicodin. Okay? Now, where should those complaints go? Who needs to be brought in? It's the medical boards. Now, Pat Irwin, for those of you who don't know her, she was a nurse. She was worked up to be a high executive with Kaiser. She's now dedicated to this cause. And Pat, you're going to now take over the rest of this program. Tell us about the campaign to protect patients in pain and what problems there are, and then get us started on what can we do about this. Pat, where are you? Come in.
I am right here, Dr. Tennant. Thank you so very much. I'm very honored to be here tonight. Before I get started, I want everyone to know I'm going to cover a lot of material. Don't worry about taking notes or remember what I'm saying. I'm going to put everything on the DocToks Facebook page. So everything we talk about, you can go and look it up. And I'm going to be monitoring that post. So if you have questions or comments after this after our show tonight, please feel free to add it. If you don't get your questions answered tonight, I want you to know that that's going to be ongoing. So, so tonight I'm going to start off by telling you there's something really wonderful that's been in the works now, and very happy to announce it. There is now an official alliance between DocToks and the National Campaign to Protect People in Pain. I'm very pleased to announce that, and I'll go into detail about what that means and doesn't mean in just a bit. How it got started was Dr. Tennant was looking at our program, and he realized that there were areas where we could be a little bit more goal-oriented, action-oriented in some of the things that we were doing. And he talked to Red about how that might work if we worked together and worked on projects together. And they both came to a consensus that they would like to try that for the next month or two, see how it goes, get your feedback, and then we'll take it from there. So it's definitely a collaboration from two leaders and two groups. We're very proud about that. So the members of who's on the, essentially this is the NCP3 or National Campaign Board. And you'll recognize a lot of folks on here. Dr. Ibsen is on here, Monty Goddard, Kristen Ogden. So these are folks and names you probably have heard of. It's Richard Lawhern is our leader. He gets very upset when we call him that. He says, I'm just one of the gang, but he is definitely our leader. And he's thrilled about this collaboration. So we're very, very happy that he's on board with all of us. A little bit, I'm not going to go into detail, but just a little bit about what the heck the National Campaign has been up to. In the last year or two, we've done some presentations to the FDA, the National Institute of Drug Abuse, also special presentations to key health leaders in both the House and the Senate. Working hard, as you'll hear more, on the guidelines, opioid prescribing guidelines, specifically for the California board, but we're looking at expanding. So we'll show you more about that in a minute. And we're fighting really hard against the negative effects of the national opioid settlement injunction. It has caused so much harm, and we're really, really, really working hard on that one. So let's now talk, a little bit about the national campaign. Let's talk about the alliance for a minute. Very important. Both groups are going to maintain their identity. Nothing is happening to DocToks. It's here as strong as ever. Both groups, part of the reason we decided for this collaboration is really both groups share the same mission and vision. Both groups want to get rid of this false narrative where we are blamed for every problem there is with the opioid crisis. That's the false narrative. And we just know that that is not true. We definitely want to restore the doctor-patient relationship. That's a fundamental goal of both groups. And we'll be working on that. And having patients receive their legitimate pain medications. So those principal goals that NCP3 has are obviously goals that DocToks has, and it just makes sense that we don't work separately in silos, that we work on those together. We can work on initiatives when it's appropriate. Not everything that DocToks does, NCP3 will want to do, and vice versa. So there'll be some, some filtering of what makes sense for us to work on together and what's going to remain separate. Really nice is that the leaders, Red and Dr. Tennant, will be able to share email lists and all of their distribution when they want, how they want, but that will give them, lots and lots of spread that they don't have now for what we're trying to get across. We can share our accomplishments all in one spot when we do it. Red puts out a quarterly update and a yearly update on the things that we're doing, and everything that DocToks does, we can put in there. So it really will shine a light on the accomplishments that DocToks has. Speakers and presenters can be available for both groups. So there's experts on both sides of the house, and so we can have pharmacists from that group come here and pharmacists from DocToks go there and talk and join, and it should be really more advantages than I think might be bumps in the road, although I'm sure there'll be bumps in the road. Okay, so that's kind of what it is. Well, what isn't it? It is not replacing Dr. Tennant. Dr. Tennant's role in arachnoiditis education is all just like it's always been, you know, and he's been the guiding light on that for so many years, and we're counting, obviously that will continue. It doesn't replace the support and network that we get from DocToks. I mean, DocToks really is a family that's been built over time. It's there all the way. I can feel it from the admin group to the moderators down to the members. And everyone supports each other in a way, honestly, doesn't exist in a lot of the other forums. And that is definitely going to stay. And as I mentioned, it doesn't replace our DocTalk experts. We have all of our great people that have done so many amazing things, and we're going to keep counting on you guys to keep doing what you're doing. One quick thing is you may have heard, I want to clarify, you may have heard the term, Red's been throwing around a term named meeting house. And I wanted to clarify how this is related to it, but it's not exactly the meeting house. In Red's vision, the meeting house is leaders are sharing their emails together. So from any group that wants to, it's all voluntary. And then when something urgent or critical comes up, they can get together, share, and mount hopefully a response that would be quicker if there wasn't a meeting house. And I'll give you the best example was just recently the FDA was looking for feedback. They were looking at the studies that were done on extended release opioids, and did they need to put stronger labels on? This was huge, and obviously we needed to mount a very quick response and a very strong response. The meeting house wasn't in place at the time, and honestly, it was thank you to Monty Goddard for getting that information and getting people working on that in a timely manner. And there's sometimes when one group knows and the other groups don't. It's just critical that we communicate with each other. So that's the purpose of the meeting house, if you hear Red talk about that. And I'll certainly alert you, and Monty, I'm sure will alert you if we see something at the meeting house that needs to get brought here. I can guarantee you that we'll get you that information. Okay, I'm going to pause for a minute because there's lots more to come, but there's a lot to digest, and I want to give everyone a chance to ask questions about the structure so far, questions about NCP3, questions about the Alliance. You can type them in the chat. I can see your chat, however you would like to do it. Does anybody have questions so far? All right, if you do at the end, we'll have lots of time for questions at the end, so not to worry. So let's talk a little bit about long-term visions for the Alliance. It's pretty obvious, and NCP3 suffers from this as well. We all tend to talk in what is colloquially known as an echo chamber. We talk to ourselves, we talk in our own group, we complain to each other, but we don't get the message out of the pain community. It's absolutely critical. And even talking to other groups, we're still in the pain community. So part of the long-term vision of the Alliance is we break out. And I know that's not easy. We've all been trying, but hopefully with the two groups together, we'll have a better chance of breaking out of this echo chamber. A good example of this is the ribbon campaign, because the purpose of the ribbons is what? It's to talk to other people not in the pain community, talk to somebody in the supermarket, or talk to somebody at your child's school. So anything that breaks us out of this capsule that we're in is part of this vision, and the ribbon campaign is a really good example of that. And the ribbon campaign is not going away. It's definitely staying. Long-term vision also is there's so many skills we all need to do action. How do you present to a board if you're going to present to the board? How do you write a complaint? Some of us have done it before, some of us haven't. How would you write to the board if you wanted to write to your medical board? Those are all skills that we don't expect you to have starting off. Part of this, there's going to be a lot of education that comes with this, not just throwing out, nobody's throwing anybody into the Shark Tank. There's going to be a lot of support and education that goes along with it. Members will know the current structures and forces that define the current pain management landscape. Well, what the heck do I mean by that? When you look around at the pain situation, the structures and the impediments you look at, it's all the things we talk about all the time. The structures would be the FDA, the opioid injunction, the DEA red flags. All of those things are the current structures that are impacting us. And we want, again, the last one is to give you the skills and the strategies to be able to work in that landscape and be as effective as possible. So initiatives, we talked a lot about starting to become action oriented. And one way you do that, a group can do that, is by looking at selected subjects that you want to tackle and to accomplish. A group can clearly handle multiple not mature is not the right word, a group that's been working together for a long time can handle more than one initiative. But when you're new and we're starting out, really having one new initiative is going to be plenty for us, more than enough. And that doesn't mean we don't keep up with our older initiatives like the ribbon campaign. But we're going to pick one initiative to try. Remember, all of this is a trial, a 1 to 2 month trial, just to see what happens and get feedback on, is it working? Is it not working? What do we want to do? We wanted to pick something that everybody in the group could work on. We're clearly aware that so many of us suffer in such ways that it's really difficult to, pick up the phone, call someone and talk to someone. But we're hoping that we're going to structure in a way that everyone can participate to some degree. There's always some room for all of us to participate. And as I go through, I'm really going to try to point out, well, these are something that you can do, even if you're bedbound, even if you're having a bad day. What are some of the small things that you can do? Part of that is education and learning, and all of those things, can be done even if you're horizontal, like we often have to be. And it needs to be doable. There's just some, like tackling the DEA right now is something that would take a group a long time to have the sophistication to do. Not that we can't try. I know David is working hard out there with all his court cases, but that an initiative of that magnitude is probably too much for us to start out. So with that in mind, Dr. Forrest, Tennant, and Red got together and with input from Monty and Kristen and Jamie and myself, and we really looked at what would make sense to tackle as an initiative. And we know that the state medical boards, some are easier to work with than others, but if we were to tackle the opioid prescribing guidelines, we could accomplish a lot. The other fact is that some of us have had a lot of success working on the guidelines in California. I realize that doesn't translate to some of the other boards, like Montana and Maine are going to be a challenge, but we have to start somewhere. We have to keep pushing and not be silent, or we are never, ever going to get anything done. No one is good, as Dr. Ibsen tells us, no one is going to do it for us. We are alone in this. And so we're going to have to, and we're going to have to push. So we're going to try this initiative, and I'll give you a little bit more detail on what that is. So before we go into what we're going to do, I'm kind of going to give you a little bit step back of how we're going to look at the goals. And I don't know how many of you have gotten this in any of your past college education, but there's something called SMART goals that are very useful. It seems overly structured, but they're very useful in tackling things like we're going to need to tackle with the medical boards. And all it stands for is the S in SMART stands for specific. So you really got to define exactly what you're doing today. Are you making a phone call? Are you going to write 10 letters? What exactly you're going to do? And if there's questions on who's going to do it, it needs to have the who in there as well. It needs to be measurable. For example, you wouldn't want to say, I want to feel better by the end of the week, even if we would all like to feel better by the end of the week. It would have to be something measurable, like I walked 2 blocks further, or, whatever blocks that is, 10 blocks, or I lost, 2 pounds in 2 months. Whatever that goal is, has to be measurable. It has to be achievable. Like we mentioned, for us to tackle the DEA right now would probably not be attainable. It's not that people individually can't try, but it didn't make sense for it to be a principal initiative. It has to be relevant to the big picture. The big picture, remember, was we want to get rid of the false narrative. We want to get the doctor-patient relationship back, and we want to get patients their meds. Those 3 things, we want those things to happen. So whatever goal we're working on had better kind of support the long-term vision of where we're going. And SMART goals need to be time bound. So it's really easy to say, I'm going to write a letter to, my state representative. And if you know as well as I do, if you don't put a time on it, a week is going to go by, 2 weeks are going to go by, and it just kind of doesn't get done. So that has to have some time limit, 2 weeks, whatever is going to work for that particular goal. Here's finally, Pat Irving gets to it. The first SMART goal we're going to have, and again, this is a goal that NCP3 folks are going to work on as well. This is a alliance goal, a collaboration goal that all of us are going to have. And we want folks to use your computer, do a search, look for your medical board's website, and look around and see if you can find guidelines. Can you find guidelines? So it doesn't matter right now which search engine you use. Do you use Firefox or Google, or if you're really sophisticated, you use Perplexity AI. We'll talk about that later. For today, it doesn't matter. You just want folks to go and do a little searching and see if they're first go look at the medical board and then see if they even have guidelines. If they do, pay special attention to if they have a definition page for pain. That would be really great to note. Take note of that. It'd also be really great to take a look if they have anything about forced tapers. They may or may not. Those are just kind of side notes there. A bonus goal would be, if you find your guidelines and you're comfortable with that, if you have time to search a little bit for any state laws that your state might have that's relevant to opioid prescribing, like we have an intractable pain patient law in California that's served us very, very well. Thank you to Dr. Tennant. So we're very, very grateful. We're so fortunate in California. Other states just don't have laws like this that support our patients. It's measurable. We would like you to be able to report back at our next advocacy session. And I'm only going to do those every 2 weeks for right now. We want to give you time to do the goals that we're putting out. And we want time so that you don't feel too rushed, but you know it can't wait forever. And then we want time to collate that information. So the next time we have a session will be on June 26th. And if you can be prepared to report back, that would really be super. That would be great. Achievable, like I mentioned before, we know some of you are really suffering. Do the best you can. Do what you can do. Try to do something. But again, we know everybody's in a very different situation. This goal is relevant. It's the beginning step in learning how to advocate for your state medical board. I'm going to talk more about where we're going with this in a minute. And it's time bound. Again, please do this before June 26th and be ready to report back out. So thoughts. I know this seems really structured. I would probably be running for the door right now. Oh my God, what is Pat Irving doing to us? But it's a trial. I think it's good to have some structure starting out, easier to kind of know where we're trying to go. We can loosen it up as we go on if that seems like it's helpful. But for right now, we'll try. We'll try for the next month or two and see where we go. Your first attempt at things do not have to be perfect. I cannot say that enough. You're probably thinking, oh my gosh, I've never spoken to the board. What would I even say? And we're going to have lots of practices and things like that. But even so, the first time you do something, it's not going to be perfect. I have stuck my foot in my mouth on occasion at more than one board meeting. I try not to do that, but none of us are perfect, and we're all just trying to do the best job that we can do. And I want you to ask for help. If you remember, I said all of these goals will be posted on the Facebook page on DocToks, and I'm going to be looking at that section. And even with this first goal, if you write back and you say, Pat, I can't find my medical board. Do I help? Just write it down. I'll be monitoring. I'll get back with you and we'll see what we can do to help. We're all learning together. There'll be some bumps and there's some twists in the road, I'm sure. But we've got such a great group here. DocToks is just, I can't say enough. I know that all of us together, we're going to help each other out. So nobody has to do this alone, for sure. So I promised I'd give you a little idea where we're going with this. So, what's the point on looking to see if I have guidelines? What good will that do? Well, hopefully at some point we'll be able to influence the fact that your board has bad guidelines, they're prop infected, or you don't have any guidelines at all. So there's going to be a long-term goal, obviously, of influencing what you find. We're going to not this time. In the future, we want you to listen to your board meetings. Some meet monthly, most meet quarterly or less frequently than that. Find out when your board meets and start listening in. It's all not going to be related to pain management, trust me. Sometimes there's agendas that the entire agenda, there's absolutely nothing about pain. And I'll talk about that later. But there's always usually something of interest. You don't have to listen. Sometimes there's all day. You don't have to listen to all day. Look at the agenda, pick a little section that you might want to listen to. The goal is really, you want to familiarize yourself with who the heck is on my board? Who are those people? What are their roles? And learn them. Just soak it up. Learn as much about these people as you can, because they're the people we have to convince. It's not our friends. It's not other pain patients. It's these people sitting on the board are the people we really have to influence. And Dr. Ibsen will tell you that's not always an easy task. So familiarize yourself with the board. And then each of you, and you can all do something different, design a plan for intervening with the board. And what do I mean intervening? Make a written comment. You don't have to talk in person. You might want to make an oral comment. And you might want to make a complaint regarding your own care or support a patient in making a complaint. I'm not going to give her name. I'm very, very proud. We have a person in the audience right now who has put a complaint in with her board, and she's fighting tooth and nail, and she's not healthy. She struggles like the rest of us, and I'm so dang proud of her. So you just, they've got to hear us. They've absolutely got to hear us. So proud of her. And when you get a plan, you can review that plan with us, review that plan with DocToks on our advocacy show and say, I want to try writing a letter, but I'm not sure what to say. And we'll all jump in and give feedback. When you feel comfortable with what your plan is, execute the plan, go do it. Go, and again, not going to be perfect. You can always get support from the DocToks group. I'm here, Jamie's here, Dr. Tennant's here. Hopefully in the future, I'm not going to call on them now, in the future, Monty Goddard and Kristen Ogden hopefully will be available to be part of that advocacy team. Really hoping. And then once we get people's feedback, I have a grid, of course I do, with circles and arrows, and I'm going to monitor our progress with each of you on how you're doing with your goal and how the group is doing overall. So closing thoughts. Our alliance will hopefully stand as an example for others. As far as I know, this is the first time it has been done in the pain community, maybe a long time ago before I came on board, but certainly within the last 2.5 years, I have not seen groups try to do this. So I want us to be an example of what can be done together, a model. It's something hopeful and positive when things are honestly not looking real good right now for the pain community. So it hopefully a positive thing. And we can go from there. Now, the next piece for the future, and I really hope you feel comfortable at least giving me your initials. In the chat section, as we're finishing up, if you can just type your initials and your state, what state you're in. I'm going to use that in this template. It's not going anywhere else. It is never going outside the alliance. This is just for me and Dr. Tennant to kind of keep track of where we are, who's in what state and what's going on. So if you feel comfortable with that, that would be really good. And that's all I have, except to open it up for questions.
Let me ask, I've got a question that I think we need to talk about for a minute. Would you, I think very few people understand this. Would you explain a little bit about who's on medical boards?
Yes.
Everybody's heard it, but how do they get there? Who are they? How are most of the medical boards even derived, or who are they?
Each state is, thank you, Dr. Shen. Each state's very different. They're usually, the governor has some role in appointing them. They're not all physicians. This is very important. Matter of fact, on the California board, Monty, jump in, there's 4. I don't think there's more than that. Oftentimes they come with a business background. Sometimes there's pharmacists even on the medical board, or people from the community that want to serve that role, because the board again is to serve the community. They are there, and this is the important part. They're there to provide and protect our safety. Right. So it can be members from the community that are on the board. They often have an executive director. So they usually have a president who will run the meetings and get votes for the things that they're voting on. They usually have an executive director or someone in that role, and that person is going to kind of be the doer. They're not the true leader of the group, but the executive director will carry out the initiatives that the board wants them to do. So that's important to know. So thank you, Dr. Tennant. So really look to see who's on your board, what's their background. And the other thing is, Dr. Tennant, how long have they been there? We're finding with the California board, boy, they rotate, and we have all new people. And
Yeah.
now we're faced with new people.
This is exactly one of the points I wanted to make. They have this immense power, but they're not physicians.
No,
They're political appointees by the governor or the state legislature as a rule, and they turn over a lot. Now, the next question, where do they get their information?
they are open to the public, so they have several ways of getting information from the public, and that is they take comments, and this is where we come in. At the beginning of every meeting, almost for all states, they will take comments from the public. Both you can go in person to most of these meetings, depending on the state, and you can go up to the microphone when the time is ready and give your 2 cents. They get feedback by people writing in, or if you're listening in, they're required to allow time for questions on every agenda item, and then you raise your hand and they call on you and you speak up. And so they're getting information from the public. The problem is not enough people are there giving feedback. I bet you 90% of the boards have not heard from a pain patient, right?
There's another very important factor here.
What's
Um,
that?
and that factor is that the medical boards are a division of the Department of Justice in the state. And the lawyers that work for the medical board are the ones that inform the medical board members. So they're getting their information from law enforcement,
That's another
unless
big
we give them different information. So that you can bet that the default information they got is, no Holy Trinity, and none of this and none of that, and no soup for you is the default way of being until we interrupt it with actual facts.
Thank you, Dr. Ibsen. Absolutely. And in the case, now it's a different a little place. Our board is part of the Consumer Affairs Department, but regardless, Dr. Ibsen is absolutely correct. When it comes to discipline, they are linked to the attorney generals. So you're right. When it comes to which doctors are going to get penalized, where do they get their information? No, Dr. Ibsen is absolutely correct. It is coming from the attorney generals and the DOJ.
We have we only have a minute or so left.
Okay.
Let me ask you this, to close this out, and thank you so much. Mark, thank you so much. You've been with them quite a while. This needs to be done. I'm going to bet that if you surveyed all the medical board members in our 50 states, I would bet you that the vast majority think there is no pain problem in this country.
Yeah.
I'd also bet you they think there's an overdose problem in this country.
Yeah.
But I'm going to bet you that not a one of them believes that there's a pain problem. My personal social friends don't think there's a pain problem. They have been told in this country that people are being treated for pain. There is no pain problem. It's all an overdose problem and an opioid problem. Do you disagree with that?
Yes.
Very much.
Yeah.
Yeah.
That's
This is Martin. I would
Go
have
ahead,
to
Martin.
clarify, in California, having worked with them for a couple of years now, I think they're kind of unique in that they don't really fit that mold. There's a lot of people on that medical board that understand what's going on. They made an attempt with their new guidelines to try and fix it. But just like the laws that have been passed in other states and the Intractable Pain Act and the Pain Patient Bill of Rights, there's so much out in the general population that the efforts that California has made have not really borne fruit. And that's true in many of the states who've passed the laws recently. I could list them, there's 7 or 8 of them. Arizona's one of them.
Okay. Well, thank you so much, Marty. We're out of time. Thank you, Marty and Pat, Mark, all of you who have put this campaign together. DocToks, certainly we're here to support it. That's clear. I think we're going to get somewhere. Thank you so much.
Thank you, Dr.
Jamie, thank you again for a great program. We'll sign off tonight and we'll see you next week. Good night.
Good night.
May I interrupt? I posted a notice that I sent to the CDC, and it is chock full of all of the valid research and information with links. So I put that in the chat.
Oh, perfect. Yes,
Wonderful.
please
Thank
feel
you,
free to
David.
put stuff in chat.
I can put it in the Facebook too.
Oh, that'd be even better. Thank you
That'd be
so much,
great,
David.
David.
Thank you all for joining us this evening, and we will see you next week. You are not alone, and please stay alive. Thank you so much.